Hello, I'm Drew Klein. I'm one of the interventional cardiologists and vascular and endovascular specialists here at Piedmont, Atlanta. The pleasure of presenting today about peripheral vascular disease. So let's get started and talk about why peripheral vascular disease is important and really why should we care, both for the internist side but also for the cardiologist and vascular medicine specialist and across all spectrums. This disease is very prevalent and it's important that we get the word out there about it so we can start preventing it and hopefully treat our patients when we recognize them as having this critical disease. So first of all, I have no financial disclosures. I'm happy to take anyone's money if you want to give me some. I am an internist. I still board certified in internal medicine. I believe that this is a disease that is very important to understand at the internal medicine level. When I did my medicine residency, I actually received 0 lectures about it, which is unfortunate. And this is why it's my passion to really talk about it to all specialties across the field. I'm also an interventional cardiologist and do endovascular procedures as well, but this is my true passion in life, is to be able to discuss this disease with you, and I appreciate the opportunity. First of all, I think it's best to understand where we're going today, and that's to understand that peripheral arterial disease is very easy to diagnose. It has a significant clinical impact, and we really want to go over the current guidelines and understand that really providing a systematic approach for all patients who have come in with peripheral arterial disease. And then understand that you need to make this diagnosis. It doesn't matter if the patient is asymptomatic. So those are going to be our 3 goals today, and hopefully we'll walk you through this as we start. The first thing is that peripheral arterial disease, and actually from interventional side, has been discussed and been on the forefront for many, many years. In fact, this is Charlie Dotter, who was the first interventional radiologist actually to do a peripheral vascular procedure. It was actually the first peripheral balloon angioplasty. It was the only balloon angioplasty ever done in the 1950s. And his idea was that if a plumber could do it with some pipes, then he could do it with some balloons. And he invented a catheter technique which is called dottering. And the interesting thing about this first case, this was an 80-year-old woman who presented with critical limb ischemia with dry gangrene of the 3rd digits, as you can see here across the forefoot, that it was very controversial at this time for him to do any of this. He opened this up with a very crude series of techniques where he basically just pushed catheters across this blockage in the SFA, as you can see down here on the bottom right panel, and the wound healed. The patient went on to have a small amputation or minor amputation of these toes, but the wound wound up healing. The patient died 3 years later of congestive heart failure. And I think a couple points from this first case ever done, which was, number one, this is potentially a venue for patients to save amputation because this patient was looking at a below the knee amputation at the time. And number two, this patient didn't die from this. The patient died from congestive heart failure, cardiovascular morbidity and mortality, some 3 years later. So it's critical to recognize these patients, as they often don't die from the peripheral arterial disease. They die from cardiovascular causes, hence the interest of cardiologists in this field. First of all, let's talk symptoms and understand terminology. First thing is intermittent claudication. When someone speaks about intermittent claudication, what do they mean? Essentially, it's a supply-demand mismatch in a muscle subset anywhere, either usually in the calves, can be in the legs, could be in the gluteal muscles, could be even the upper arm for patients that have subclavian stenosis, such that when they exert or need more blood supply to that area, they cannot get enough. The muscle reacts by getting lactic acidosis and it starts aching or painful. It causes the patient to slow down. They rest, relax, and the supply-demand mismatch equals out and the symptoms abate. I think the critical thing is that it does not resolve with continued activity. And there are some other mimickers of peripheral arterial disease, like pseudoclaudication, which is from spinal stenosis. And many of our patients have back pain or chronic herniated discs, and sometimes it can be very challenging to decipher. Or they may have two different processes occurring. Pseudoclaudication, the classic example, is where they feel better going uphill because they're leaning, taking pressure off their spine. Patients with PAD don't feel better going uphill. They hurt more because there's more increased metabolic demand. And then there's a bunch of random diseases out there that you may or may not see, called FMD or in cyclists, iliac syndrome. Again, things that are on the list for us who are into the vascular medicine world, but things that keep note of because they may occur. Specifically, large vessel vasculitis, especially in our older individuals, including giant cell arteritis. That usually can present with a jaw claudication, actually, where people get cramping while eating in their jaw, and that's a common sign, or actually most specific sign for giant cell arteritis. That's important to diagnose because those patients can go on to have issues with blindness if they're not treated with steroids. Also very important because of the temporal arteritis that occurs with it. What about critical limb ischemia? What do we mean by critical limb ischemia? That's essentially when you get such supply and demand mismatch in your leg that you get tissue loss or rest pain. And classic rest pain for peripheral arterial disease is described as pain in the limb when someone lays down at night such that they have to dangle it off the edge of their bed to be able to get enough perfusion. The dangling off the edge of the bed allows gravity to take effect, and essentially that extra push coming from gravity pushes enough blood flow down to their foot so that their pain abates and they can get some sleep. This is chronic, not acute usually. This usually occurs over a long period of time. It can present with rest pain, but also non-healing wounds. And it's important to take off your socks and shoes of all your patients that have peripheral arterial disease in the clinic, but especially your diabetics, because you might be very intrigued by what you find. I remember one particular case where I asked a patient who was diabetic to take off his socks and shoes. He had one toe that was completely dry gangrene. It looked like it had been there for months. I asked him what he thought was going on with that. He thought it was sock fuzz. So you cannot make this up. Patients are in denial a lot of times about what's going on, and it's up to you to actually take a look and really understand what's going on with these patients. I just saw a patient yesterday who had been discharged from the hospital. No one had looked at his wound on his foot for 5 days. He'd been seen by other providers and no one else had looked at it. It's actually now infected. So it's important to just take off the socks and shoes, unwrap the bandages, and really look at what's going down at the foot level, because this will give you a marker of the arterial inflow. So I took this slide from my mentor, Ivan Kasserly, who came up with this idea that PAD, especially for the cardiologist, I think this really makes sense. PAD, when you look at it compared to CAD, has a nice progression, and that's, if you look at claudication, it's very similar to stable angina. This is a green zone. Most of these patients are stable. We know most of these patients can be treated aggressively with medical therapy. That is the baseline and the foundation of all therapy for peripheral arterial disease. But most of these patients do quite well. We know that long-term their outcomes will do quite well. However, some will progress and they'll go on to rest pain, or what we'll consider unstable angina. And then when you get to gangrene or wounds, so you're really talking about patients with the highest cardiovascular risk, and that's equivalent to those patients that present with non-STEMI and STEMI, because we know those patients have the highest MACE outcomes at 1 year, a major adverse cardiovascular event. So this is a nice way of looking at it, and I appreciate Ivan sharing this slide with me. So what are the risk factors for PAD? Who should you be looking for? I think most of the time in these patients, we're already screening these patients and looking for them, but we're not perhaps understanding that some risk factors are higher than others in terms of for PAD. Specifically, smoking. Smoking is number 1, 2, and 3 out there for risk factors for peripheral arterial disease. Diabetes is probably number 2, and then advancing age is number 3. So though male gender, race, hypertension, all these things that we know for cardiovascular disease is a risk factor, the 3 big ones are advancing age, diabetes, and smoking. That's just it, 3 things. And for your patients that are in those, the more components they have, the higher their risk. So here's an example looking at that across, if you look at a heart hazard ratio, and that just confirms again that smoking, diabetes, and age are really your biggest risk factors for patients that have peripheral vascular disease. And as we get older, the prevalence of peripheral vascular disease increases, such that it's much higher in the 70-74 population, almost 7 or 8%, when compared to the 55 to 59 or less than 50 population. So usually 50 and above is the part where the patients we should be looking at, though in smokers this can be much earlier. So how prevalent is this disease that we're talking about? In reality, these patients are much more prevalent than most of us even appreciate. In fact, if you look at the Partners trial, which was now almost 20 years old, looked at 7,000 patients who came in to primary care offices at 350 sites, and they just said, let's look at all patients who are ages 50 to 69 with any history of smoking or any history of diabetes, or all patients greater than 70. What is the prevalence in that patient population? And I urge you to think about the patients that you see in clinic. How many fit that patient population? In my clinic, that's probably 95% of what I see every single day. And they would give them the PVD diagnosis if their ABIs were abnormal. We'll talk a little bit about that, or had they a prior diagnosis of it. And the amazing part is PAD was detected in almost a third. That's 30% of all patients who fit this category. So if you look at your waiting room, and your waiting room is composed of patients that are 50 or older with any history of smoking or diabetes, or greater than the age of 70, regardless of history, 1 out of 3 will have peripheral arterial disease. 1 out of 3. So let's get into why that's important to make these diagnoses. First of all, the shocking aspect, and underscoring the aspect that we are not educated about this as internists, is that 49% of PCPs were unaware of a prior diagnosis of peripheral arterial disease. It is just not on the spectrum. It's not on the curriculum. Like I said, I had the opportunity to train at a major university center for internal medicine at UCSF, and I received 0 lectures on this. And it's important that we really get out there and educate our patients, but also our providers about picking up this diagnosis. So we're not this guy or gal that doesn't understand that, in fact, your patient has PAD. New diagnosis amongst this group of 30%, by the way, was just a little bit greater than prior diagnosis. So 2 big issues there, that PCPs weren't aware of it, but also that you could pick this up in almost 50 to 60% of the time. So the reason why this disease is so challenging to understand, and so challenging that we just don't talk about it, is that it's asymptomatic as the rule. Most patients who have peripheral arterial disease actually don't have symptoms from it. So how do you pick up a disease, or how do you even think about a disease if you don't have any symptoms? But let's just talk for a second how asymptomatic and how this can be lurking in the distance or lurking in your patient and not even realize. It's very covert. If you look at the WALKS registry, and these are all patients that had pretty impressive peripheral arterial disease, only 33% actually had intermittent claudication. If you look at partners, so again, of those 30% of patients in those categories that had PAD, only 2.5% actually had symptoms. So it's not surprising that we don't go looking for it. However, if you look at the clinical impact, the clinical impact of making diagnosis of peripheral arterial disease is this. It doesn't matter if you're symptomatic or asymptomatic. Your mortality is 2 to 3 times age-matched controls. Your 5-year mortality with peripheral arterial disease is 30%, and your 15-year mortality is 70%. And how do you die? You die from cardiovascular disease. So if you make that diagnosis early, you can get your patients on the appropriate therapy and hopefully reduce this mortality. In fact, 60 to 80% of patients with PAD have at least significant coronary stenosis in one coronary artery, and a quarter of them actually may have cerebral or carotid disease as well. This is why we have to make this diagnosis, because these are how these patients are dying. If we can get aggressive about prevention, we can get aggressive about treating these patients and hopefully saving some lives. Additionally, let's go on for those patients that actually maybe have symptoms and or are on the verge of having symptoms, perhaps, or wounds. It is a major risk factor for amputation. Many diabetic foot ulcers also have peripheral arterial disease. I cannot tell you the number of times that we've had to revascularize patients that quote-unquote been labeled with diabetic foot disease for a year or plus. In reality, it's a concomitant process going on. If you fix the arterial disease, it actually improves their wound healing and allows them to actually go on a walk and not get an amputation. Additionally, if you look at the quality of life for patients with critical limb ischemia, it is miserable, absolutely miserable. Patients that have rest pain or wounds have a quality of life equal to that of terminal cancer. It's very important that we give these patients treated aggressively, try to get their wounds revascularized so that their quality of life can greatly improve. But that is on a foundation of solid medical therapy. And the interesting aspect about this, and this is a lot of work coming from Mary McDermott's lab, and from her studies have shown that no matter if your patient says they're asymptomatic, when you actually push them and delve into are they really declining, a lot of functional impairment and decline is common. So it gets written off as, a doc, I'm just getting old. But in reality, if you ask them how far could you walk a year ago, maybe a block or two, and now they can only go a half block. The reason is that they just feel weakness, and they can be atypical symptoms. So just like we know our diabetics and our elderly and our female patients can present with atypical chest pain, that could be coronary disease. Same thing here with PAD. Weakness or just loss of power is not an uncommon symptom. So they ascribe it to getting old, but in reality, it's peripheral arterial disease. So how do you make this diagnosis? Well, it's an ankle-brachial index, and usually if I'm giving this talk live, I actually ask how many people have actually performed an ABI. And most of the time it's around 5 in the audience, maybe 2. And the reality is this is a very easy to test that you can actually do in the office. When I was a fellow, I was having my MAs do this when I was a fellow, and now I use our vascular lab, which is phenomenal. And it's really assessing the ankle blood pressure versus the brachial blood pressure. And I think a couple things come out of this. Number one, you got to know how to do it and to take the highest level, but it's important because you'll start noticing, for instance, some patients walk in, they have a 40-point difference between their left arm and their right arm, that no one's made that diagnosis before. And that can be from left subclavian stenosis, for instance, if it's on the left side. That plays a huge clinical importance because for years, perhaps they've been checking the left side for blood pressure and making blood pressure changes or decisions based on a falsely low blood pressure. And I've had countless patients show up with flash pulmonary edema or hypertensive urgency. In reality, it's because we thought the blood pressure was 120 based on the left arm, but in reality, the real blood pressure was somewhere near 180. So it's important to make these diagnoses, and you can do it right here in the office. If you don't remember how to do an ankle-brachial index, and if you don't want to send them to the vascular lab, you can always look on Google and look up how to do it. It's very easy. It's just using a blood pressure cuff and a Doppler, and you can just measure pressures at the PT, the posterior tibial, behind the ankle, dorsalis pedis on top of the foot, and then the brachial at the radial. What are normal values? These kind of go back and forth, usually about 1 to 1.3. Once you get over 1.3, that's a non-compressible vessel. We'll talk a little bit about that, but in reality, those are patients that have such medial calcification of their infrapopliteal vessels that when you go to blow up that blood pressure cuff to 300, they actually you just can't compress the vessel. And that is a marker of arterial sclerosis, is a marker of medial calcification, and it's a marker that your patient has bad vascular disease. As your ABI gets worse, the symptoms usually creep up, but it also is a marker of increasing vascular disease burden. In fact, if you look at abnormal ABIs, and just let's look at some important things like mortality. Okay, as your abnormal ABI across the board, the lower the number, the worse the mortality. Abnormal ABI and heart disease. Again, the more vascular disease burden in your legs, the greater chance that you're going to have a vascular event in your heart. And what about in your brain? Carotids, intracerebral. Again, more vascular disease in your legs, you got it. It's a total body process. It doesn't just work below the legs or in the aorta. In fact, if you look at the curve, it's a U-shaped curve for ABI, and then it means on the low end, if it's 0.4 or 0.5, huge mortality here, and you can see here for cardiovascular disease mortality as well. There's a direct correlation here. And the lower you get, the higher the mortality, but also on the opposite side, once you get over the non-compressible vessels. Well, that's because who gets non-compressible vessels? Is diabetics with end-stage renal disease are usually your patients that get medial calcification. Those patients have an extremely high risk of cardiovascular disease and all-cause mortality. So ABIs, let's go a little bit through the guidelines. So guidelines from 2005 versus the guidelines in 2016. And really, the prior guidelines were based on the partner study that I showed you, basically looking at 50 to 70 with any history of smoking or diabetes or greater than 70. New guidelines are basically anyone who has any history or physical exam suggestive of PAD, or in patients who are at increased risk for peripheral arterial disease. So we're not even going to age now. That includes age, diabetes, and smoking, but they're saying all comers that may be at increased risk have a 2B recommendation to check an ABI. But class 1 is for anyone who has history or physical exam findings suggestive of PAD. And just a note on physical exam findings, you can actually have a palpable pulse in your posterior tibial and dorsalis pedis and still have peripheral arterial disease. So that is a myth that if you can feel their pulse, they don't have PAD. Plenty of our patients have long-standing SFA occlusions that because of great collateral flow over a long period of time have palpable pulses. So if you can feel their pulse, don't believe that they don't have PAD. So again, why am I here and talking about PAD outcomes? Well, here is the kind of take-home slide that's important. PAD outcomes, if you look at the 5-year outcomes, non-fatal or cardiovascular events, so MI or stroke, 20%, so 1 out of 5 at 5 years will have one of those events. Your mortality will be 15 to 30%. Your cardiovascular causes will account for the majority of that. So most of these patients will end up dying from stroke or heart attack, and non-cardiovascular causes about 25%. What about the limbs? this is kind of going back to that score of stable angina and unstable angina. Most patients that have stable claudication, it's about 70 to 80%, and this is actually maybe closer to 60 to 70%. Those patients do fine. They remain stable over a long period of time. Worsening claudication is probably 10 to 30%. Those patients will progress. Again, it depends upon how active they are. And then critical limb ischemia, thankfully, only about 1 to 2% of patients will go on to go so bad as to get ulcers or rest pain. So it's a relatively minority group, but a very important group at the highest risk from cardiovascular morbidity and mortality. So what about those patients that have critical limb ischemia? Again, that rare group, 1 to 2%. Those patients are the highest risk, as I just mentioned. And the reason that they're the highest risk is because they have such vascular disease burden that they've gotten to the point where they're getting wounds. Well, that vascular disease burden is total body. And if you look at their risk of death at 1 year, it's about 25%. So when patients come in and they have a wound, it's important to understand 1 out of 4 of them are going to be dead at 1 year. 50% will be alive with both limbs, and amputation will occur up to 25% in this patient population. So based on a slide set that I got from my partner, Dr. Gornick, who's now at the Case Western in Ohio. She was previously at Cleveland Clinic. She had this great idea of looking at PAD patients in this way, and I borrowed this from her, and I appreciate her sharing it. It's basically a 4 quadruple P way of looking at peripheral arterial disease patients, and that is for all PAD patients. You need to talk about protection, you need to talk about prevention, you need to talk about plumbing. So 4P, quadruple P. So all patients are going to talk about prevention. We're going to talk about protection. We'll talk about what that means. And then for your symptomatic patients, those are the patients you need to understand about going into the plumbing aspect. So new guidelines, Heather was actually second author on this and kind of co-author on this, and that came out in 2016. It's a great document to review, and you should pull it up on if you have any questions. I think the first thing is talk a little bit about protection. So what does protection mean? It means you actually have to take off the socks and shoes of your patients and say, let's talk about your feet today. What do your feet look like? Let's talk about foot inspection. For all patients that have peripheral arterial disease, it's critical that they see a podiatrist. It's also important that they have appropriate foot care. I usually bring up with patients, if you're getting new shoes, please be careful. If you're getting blisters, we need to be really important about preventing them. And for diabetic patients, absolutely, podiatric consultation is critical. You don't need these patients trying to cut their own nails, cutting too deep. Next thing you know, you have a wound that's there. And so it's important across the board here to really understand about foot infection and spend 20 seconds talking about checking their feet every day. Especially for our diabetic patients, I urge them never to walk around barefoot. Check their shoes before they put their feet in their shoes. Check their feet every single day. I usually bring up the story of my uncle who was diabetic and stepped on a nail on a job site, didn't realize that a nail had gone through the bottom of his foot, and wound up losing that limb because of a wound infection. So I think it's critical to really delve deep into just talking a little bit about it and trying to urge them to see a podiatrist. Prevention. Well, this is what cardiologists absolutely, and probably all internists should be doing every day. It's trying to prevent your patients from dying of cardiovascular disease. Well, we talked to them about smoking cessation. We talked to them about antiplatelet therapy, and we'll delve into that. Lipid-lowering agents, antihypertensive control, ACE inhibitors. We'll talk a little specifically about them, and then glycemic control. This sounds very similar to what we do for cardiovascular disease. So perhaps, and I've had cardiologists say, well, doc, Drew, I already do this. So why do I need to even care about PAD? Because I'm already following these guidelines. It's important because if you put PAD and you look at those patients that have PAD, number one, it may remind you to actually check their feet. That's number one. Number two, to tell them about understanding if a wound starts to occur or you're getting rest pain, to actually look for it. And really, it's understand these patients are a little bit higher risk than the average patient with CV. So let's talk a little bit about smoking cessation. This is critical. Here in Georgia, if you're not aware, Georgia actually has a quit line for smoking, and they dispense nicotine replacement as well as Wellbutrin and Chantix. So it's important. They've helped over 1,000 patients here in Georgia quit tobacco, and it's critical that you spend some time in talking to your patients about them. It doesn't matter which specialty you're in. And that's because when you quit smoking, it decreases your chance of amputation, need for revascularization, and also if you've had grafts or stents, it actually really does help keep them open. It also improves survival. across the board. I don't think anyone knows it. This is a no-brainer area. So again, the guidelines are very clear about this. Everyone is aware of the impact of smoking upon our patient population, and I think it's critical to understand about the outcomes. The way I look at it, just to pass along, is I try to tell patients that quitting smoking is like a battle, taking your enemy head on, like with nicotine replacement. You may or may not win, but when you surround your patient from either side, also with Wellbutrin and Chantix, so pharmacotherapy on one side and counseling on the other, and that's again where the Georgia Quit line can really help for the counseling, the greater chance that you have of getting your patient off of tobacco. What about antiplatelet therapy? We know across the board our patients who have peripheral arterial disease do well with antiplatelets, be it aspirin or Plavix. That's debatable as long as they're on one. That's the most important thing. Across the board, data has shown that being on one of these agents has reduced the chances of cardiovascular disease or cardiovascular events. In terms of updated platelet agents, I think it's understand that as we look at what about Plavix, it's definitely been by some groups preferred as their single antiplatelet therapy agent over aspirin. I think you can go back and forth on this depending upon the data. Dual antiplatelet therapy is a 2B recommendation, but those are for our patients that are truly advanced, our critical limb ischemia patients, and that's a 2B recommendation. Most of these patients have undergone some sort of revascularization, either cardiac or peripheral vascular, and so most of them are on dual antiplatelet agent already. Putting them on it empirically may be a reasonable option. I think these patients, given that they're high risk of cardiovascular events at 1 year, remember, a quarter dead at 1 year, it's probably reasonable to have them on both. What about anticoagulation, the newer agents, but also Coumadin? Right now, at least for Coumadin, for prevention of cardiovascular disease and mortality, it's currently a class 3 recommendation. However, we have new data from Compass as well as a number of other trials showing the benefit of low dose DOACs in patients with peripheral arterial disease. This has not made it to the guidelines as of yet. However, it is something of very great interest in these patient population to understand that at least one platelet agent along with one of the DOACs may be a reasonable option. You may be seeing more of that as we get down the road here. Low dose Xarelto or low dose Eliquis, or these may be venues. And the idea behind this is going to help clotting as well. So low dose in addition to an antiplatelet. However, it has not made it to the guidelines as of yet, as these trials are within the last 3 years. What about prevention using statins? They're the holy grail. And statins are very interesting, despite our patients coming in often with an antagonistic approach to statins. I think it's important to understand and discuss this with them that statins across the board improve actually claudication. So one study, you probably couldn't do it today, but patients with PAD where it actually showed that walking distance actually got better on statins versus placebo. It improves patency of grafts, it decreases risk of perioperative events, and across the board, your patients that have PAD also need to be on statins. One of the reasons to go through and screen for PAD in patients that are at higher risk are if you're on the fence of trying to decipher should the patient be on aspirin or a statin, you can do calcium scores or you can do ABIs and either one of those things could perhaps pick off that your patient has vascular disease and get you more aggressive about medical therapy. So if you look at the data across the board for the Physician's Health Study, simvastatin reduced all-cause major coronary event, stroke, and revascularization patients presenting with or without PAD. Simvastatin was beneficial. This is now a very, very old study, but again showing the benefit of this agent in over 40,000 patients. Here's that study I discussed earlier about walking impairment and the fact that walking distance got better versus placebo on statins alone. So critical here that improves some via its pleiotropic effect. So multiple reasons to be on one. So treatment guidelines, again, across the board, old and new guidelines all recommend patients be on a statin medication. We do not have any recommendations currently right now for Repatha or Prevalent or the PCSK9 inhibitors. However, I think that data should be forthcoming, and I think if you look at the subset analysis of many of these patients, many of these trials, they do have benefits across the board. What about blood pressure control? Remember, these patients have vascular disease in their brain as well. It's very important to be very aggressive about their blood pressure as well. In fact, we need to be very aggressive about blood pressure, period, based on some of the studies, specifically the SPRINT trial, which I go over almost daily in patients that, controlling blood pressure less than 120 in a large subset of patients versus 120, 140 showed a 30% reduction in MACE outcomes at 3 years, and that's a very impressive data. Also a 20% reduction at 5 years in early cognitive decline. So blood pressure control is imperative in all patients with peripheral arterial disease. Again, if you screen these patients and you pick up that they have PAD, even if it's asymptomatic, perhaps this will increase your sensitivity to driving their blood pressure down, which will hopefully prevent their stroke and their CV M&M. Which drugs are most important? Well, we know from HOPE and OnTarget trial that indeed ACE inhibitors and angiotensin receptor blockers are probably your first-line therapy for patients with PAD across the board. And it doesn't matter if they're asymptomatic or symptomatic. These drugs have some beneficial effect, likely from improvement of endothelial function. And so these are our first-line therapy across these patients. If you look at in terms of anticoagulation, just again, warfarin's not indicated to reduce cardiovascular events right now, but again, as I mentioned, stay tuned. What about diabetes? Our patients, especially today, with all the new agents out there that decrease CV morbidity and mortality, I think it's very important to go through them and understand them, or work in conjunction with an endocrinologist and work on what the best agents are. The better control of their sugars, the better they're going to get into in terms of microvascular disease. And I think this is where you need a team approach. It's impossible for one person to do all of this, and I think when it comes to diabetes, perhaps understanding the 10 new drugs that are out there and understanding which one is important for your patients, which ones have CV outcomes, and which one is going to help preclude any events is critical. And I think it's left best to the endocrinologist. That's personally me, because I feel a little overwhelmed by all the data that's out there. And I think it's important to figure out whatever's going to help keep your patient's A1C down. Again, if you goals right now, it's basically to glycemic control. If you look at critical limb ischemia patients, we know anyone who has a wound does better if their sugars are under better control. That makes sense. We know that across the spectrum from every single surgery, but especially in your lower extremity, again, improving microvascular control. So those are everyone gets, and I just want to transition here to the symptomatic patients. So it doesn't matter if you're symptomatic or asymptomatic, you must absolutely talk about protection of their foot and understanding and getting the suction shoes off and examining them in the office, and also prevention of cardiovascular morbidity and mortality by aggressive medical therapy, smoking cessation, as we just outlined. What about your patients that are in the last group, those patients that have symptoms? Patients that have claudication or rest pain or critical limb ischemia? Well, again, there are basically 4 options. You can treat them with medicines, you can do exercise therapy, you can do endovascular therapy, or you can do open surgical therapy. And going through each individual of these, it's a little bit beyond the scope of this talk, but I'm going to talk a little bit briefly about it. What about medical therapy? There's only one real agent out there, that's cilostazol. It is a phosphodiesterase inhibitor. I think it's important to understand that this agent does interfere with a number of other agents that we're commonly using, including omeprazole and diltiazem, and for those, it's important to understand about starting at a lower dose, 50 BID. I think the other thing is to know that about 1 out of 5 patients that start on cilostazol will discontinue it because of side effects. Most common one that I see is headaches, flushing, or diarrhea. It's important to warn your patients about those before they start. If they're taking it and they're getting a side effect that's miserable, there's no benefit, they should just stop it. Again, it's meant to improve their symptoms of claudication. If you trade it off for another terrible adverse reaction, it's just not worth it. I think the other important thing is that there is a black box warning on this. Per the FDA, cilostazol is completely contraindicated in patients of congestive heart failure. The FDA has not been specific about the type of heart failure with preserved or reduced ejection fraction. I think most of us know this from the era of when there was a trial of oral milrinone and it increased mortality, and this was the basis of this FDA black box warning from the early 2000s. And so, but the FDA black box warning continues, so heart failure, doesn't matter if it's diastolic or systolic. Right now, cilostazol is currently contraindicated, so don't give it to those patients. It's effective in some patients. At 100 BID, it's effective in improving walking distance. It is to improve symptoms, and it should be considered for all patients that have claudicants, especially mild claudicants. The patients do quite well with cilostazol, and they'll hopefully remain in that kind of stable claudication on therapy. There's actually some data out there also about Slosol, again, way back into the early 1990s about preventing some in-stent restenosis, so you may be seeing it for that as well. You may see some of us use that. What about the other agent that's out there, pentoxifene or Trentol? Trentol is essentially non-effective, and it's just been shown time and time again not to be effective, so I just take it off the list. Some people are using it for some wound therapy, and there's some other applications for it, but for claudicants, just take it off your list, just forget about it. It's actually been shown to be no benefit time and time again. What about other things like chelation, vitamin E, what about vasodilator, prostaglandins? These have all shown no benefit. They're a class 3 with no benefit across the board. What about exercise? Exercise is critical. You ask, why did I get into this field? Because what do we tell patients to do? We tell them to walk. They say, Doc, I can't walk. I can't walk because my legs hurt. Well, if you improve that, you can actually get them walking, again, decreasing their cardiovascular morbidity and mortality. We know across the board that walking improves your performance, your lifestyles, your quality of life. Exercise is highly cost effective. The studies mostly have been done with supervised exercise therapy, and I think it's important to understand that it's a little bit easier to exercise when you have a guy like this behind you telling you to exercise. But for those patients that don't want to do, and by the way, this is now approved by CMS, supervised exercise therapy in cardiac rehab or a venue such as this for PAD, that for those patients that don't want to do that, they can do it at home, and home exercise, if they actually do it, is beneficial as well. This is from Case Stewart's article in the New England Journal, now almost 18 years ago, looking at exercise, and I actually just print this off on my AVS and send it with a patient coming out of clinic and say, this is what we need you to do. You want to feel better across the board. In fact, actually for all patients, even if we're revascularizing them. In fact, we know from the Clever trial that those patients that get revascularized plus do supervised exercise therapy, they actually really do the best, because then you open up blood flow and then you allow them to essentially help rebuild that muscle. And this is important, and maybe more than you ever really want to know, but if you look at muscle biopsies of these patients with PAD, they actually have a downregulation of many genes that promote muscle efficiency. So though when they have blocked arteries, there's a downregulation of numerous aspects that essentially don't allow their muscles to work as well as someone who has open blood flow. Additionally, you might even see some increased fibrosis in this group as well. So after you open up a blood vessel, you actually have to retrain their muscles as well, and that's where exercise therapy is critical. And here's some differences between supervised versus home. Again, if you're supervised, you often have somebody there working with you, and it's minimum of 30 to 45 minutes per session, at least 3 times a week for 12 weeks. Again, it would be great if we could get all patients into this. Sometimes the constraints of life preclude this from happening. So I think for your symptomatic patients in terms of revascularization, I think there's been a paradigm shift over the last 10 to 20 years, going from purely open to a more endovascular approach. And I think it's important that these minimally invasive approaches are complementary to our surgical approaches. However, when you look at the data, again, I started off this talk about understanding that medical therapy is the foundation for PAD. It's the foundation because if you stick with the guidelines and you treat with your patients with guideline concordance, i.e. foot care and protection, smoking cessation, diabetic control, blood pressure control, statin therapy, if you are guideline concordant and you have them on ACE inhibitors and angiotensin receptor blockers, in this study it actually saves limbs. So if you look at Chun's study here in JVS, that if you're concordant with the guidelines versus not concordant, and those 4 issues, again, talking about smoking cessation, getting them on good blood pressure control, getting them on a statin, and getting them on an antiplatelet, those 4 things, it actually saves limbs and it saves lives. Aaron Armstrong published this a few years ago, and again, if you talk about smoking abstinence, ACE inhibitors, and statins, across the board, if your patients are on guideline concordant therapy, they actually live longer. Why? Because we're preventing cardiovascular M&M. This is why we need to pick up our patients early so that we can prevent that morbidity and mortality. So how do you do it? We do it with a team approach. It's not just one person. It's not just one group of individuals that are taking care of patients with PAD. This is a multidisciplinary team. And I think when you talk about the interdisciplinary care team for PAD, you really need a huge group. So you need vascular medicine and surgical specialists. You need nurses. You need orthopedic surgeons from podiatric care as well. Podiatrists, understanding about offloading diabetic ulcers that also can common arterial disease. You need good vascular imaging specialists. You need orthotics and prosthetic specialists for those patients that go on for amputation. Social workers, many of these patients have major issues with access to care. You need exercise physiologists to talk to them in the rehab facility, both post intervention, but also if you're trying to get patients in for exercise therapy before. You need nutritionists and dietitians that really talk about their diabetic care, and endocrinologists. So this is really a multidisciplinary approach, and for our patients that have the advanced disease, critical limb ischemia, it's even most imperative for those patients that we really all work together as a team. I'm very fortunate here at Piedmont to work very closely and be within our vascular COE as well as our interventional cardiologist, and we all work closely together for our patients that have PAD. Again, that's on the endovascular side, but there's so much more outside of that. There's so much more of taking care of patients before they even get to the lab. And I think that's the imperative nature, and that's how you can pick up these patients in the clinic and understanding. And if you have questions, reach out to us, ask us, and how we can improve our patients' care to prevent them, hopefully, before they ever get to the point of presenting with something like critical limb ischemia. So the conclusions, PAD is extremely common. If you should diagnose this, look for it. Look for your patients that have smoking, in your patients that are diabetic, in your patients that are older. These are most of the patients that in the CV section here at PHI that we see. It's usually older patients. Patients with PAD die from cardiovascular complications, period, end of discussion. It is important that we get these patients on good medical therapy, which is the foundation of all care, to prevent that from happening. Remember, PAD equals prevention, protection, and then plumbing. If you remember those 4 Ps, you'll remember how to take care of tell your patients to take off their socks and shoes, especially all diabetics, and really talk 20 seconds about protection. Don't walk around barefoot, and please lick your feet every day. And then really establish them in a multidisciplinary teams. When I discuss this with other hospitals and across the state and the country, I always ask who's on your team. And I think it's important that you align yourself with the appropriate people and pick up the phone and give us a ring. Because I think it's important to understand that these patients are out there. They're very prevalent, and we can make a huge impact by identifying them and impacting their outcomes by talking about prevention and plumbing. With that, I'll say thank you very much for your attention.